So what I'll talk about is a little bit about the anatomy and pathology of the oral cavity and the oropharynx. And what we're going to do is we're going to step through the oropharynx, then go to the oral cavity. Some of the things we've covered already. We've changed the names, like I said before, just to confuse you. But having said that, hopefully you'll have a better perspective as well. So the first area that we'll talk about in the oropharynx, and we'll specifically talk about the tongue base. And now there are two parts of the tongue. There's this area right here, which is referred to as the circumvallate papilla. And then right at the apex of the chevron of the circumvallate papilla is the foramen cecum. Everything anterior to that circumvallate papilla is referred to as the mobile or the oral tongue, which is in the oral cavity. But this part of the lecture is going to be dealing with the oropharynx, which is that part of the tongue which is posterior to the circumvallate papilla. So on the right-hand side is a schematic illustration of a squamous cell carcinoma of the tongue and the spread patterns. One question that comes up is how do we distinguish between the oral cavity or the floor of the mouth and the tongue base? And this illustration demonstrates the transverse fibers, which indicates the tongue base. When you see the longitudinal fibers, that indicates to you that you're really looking at the oral cavity as opposed to the oropharynx. So these are two examples of squamous cell carcinoma. Again, I'm not going to go into the spread patterns, but rather just to help you generate and build a differential diagnosis. So for instance, we can see the genioglossus muscles. The genioglossus muscle is going from the geniotubercle back to the tongue base. And you can see that this mass is centered more on the transverse fibers, which indicates that it's in the tongue base. Similarly, here the anterior posteriorly oriented muscle fibers. These are the genioglossus muscles, and we can see the transverse fibers that indicate that you're in the tongue base. So the number one thing that you'll see is squamous cell carcinoma. Now, secondly, what do you think the second most likely diagnosis is going to be in the oropharynx? Squamous cell carcinoma is one. What do you think number two would be? What do you think? There are a couple of choices. Lymphoma or minor salivary gland? Ah, okay. Now, number two is actually going to be lymphoma because, as Dr. Sam referred to, it's Waldeyer's ring. So Waldeyer's ring is this ring of tissue with adenoidal, lymphoid tissue behind the tonsil. So that's the base of the ring. The lateral portions of the ring is the lymphoid tissue within the tonsils, and the top of the ring is adenoidal tissue. So when you think of Waldeyer's ring, it's not based on cross-sectional imaging, but it's looking in someone's mouth. That's how Waldeyer initially described the ring. So number two is going to be lymphoma. And then number three is going to be minor salivary gland tumor. So this is an example of a minor salivary gland tumor. It's really indistinguishable from squamous cell carcinoma. But the three things that you look at if you're looking for a differential diagnosis, or if you will, tissue guessing, is going to be squamous cell carcinoma 1, lymphoma number 2, and minor salivary gland tumors number 3. And we all know the minor salivary gland tumors, right? Benign, pleomorphic adenoma, Warthin's tumors, malignant, mucoepidermoid or adenoid cystic carcinoma. So another example of a pleomorphic adenoma, a minor salivary gland tumor involving the tongue base. I think I showed this case earlier. Now the one thing that made it kind of nice was if you look at this lymph node right here, it's actually low attenuation and enlarged. And this was actually a minor salivary gland tumor that literally metastasized. I don't know if metastasized is the right word, but it spread through the lymph nodes, through the rich lymphatics involving the tongue base. So one of these is squamous cell carcinoma, and one of these is an inflammation of the lingual tonsillar tissue located behind the tongue base. Sometimes it's referred to as lingual tonsillitis, a well-known disease entity for our referring physicians. And it's really, really hard to differentiate between the two. This happens to be the lingual tonsillitis, and this is the squamous cell carcinoma. And as previously mentioned, you know, the lymph nodes just don't help because they can be enlarged in either one. In situations like this, if you're not working at a tertiary or quaternary institution where you can just page your referring physicians and you are out in the community, it is completely appropriate to look at this and say, both of those have increased attenuation involving the region of the lingual tonsillar tissue, and it's totally appropriate to correlate this with physical exam. Because this one on the right, the referring physicians will come back and say this is soft and compressible lingual tonsillitis, where this was more rock hard and this was a squamous cell carcinoma. So realize the radiological appearance can overlap. Now, we talked about this earlier. This is the normal descent of the thyroid gland. It starts at the foramen cecum and eventually ends up in its normal resting place in the anterior neck, just anterior to the tracheal cartilages. If there is tonsillar tissue, thyroid tissue that's solid, that remains at the foramen cecum, again, solid, that is lingual thyroid tissue. And to confirm this, you can perform a CT of the neck, and you can see there is no thyroid tissue. Another example here, densely enhancing thyroid tissue at the level of the foramen cecum. I think we can all suggest this. It would sort of be unusual to have an aneurysm in this location, but you can never say never. But I think in general, we'd all say it's lingual thyroid. Another example of lingual thyroid tissue, maybe what can tip you off is the central area of increased T2 signal. Certainly a mass on its own, you have to think of squamous cell carcinoma, but hopefully you'll have the proper testing to suggest that the patient's hypothyroid. And this is the sagittal non-contrast T1 weighted imaging, again demonstrating to lingual thyroid at the level of the foramen cecum. If you have that thyroid tissue and it starts to secrete and contains fluid, remember the water balloon analogy, then you have the thyroglossal duct cyst. So both of these are related cousin solid versus cystic. So that's the first part of the oropharynx, is the tongue base. We'll then move on to the tonsil. Now, there are different components to the tonsil. There's actually 3 components to the tonsil. The primary component of the tonsil is this lymphoid tissue, which forms the walls of Waldeyer ring. So when you look in someone's mouth, remember the ring goes from top to bottom, side to side. And this tissue also is referred to as the palatine or the fascial tonsil. Again, 2 names for the exact same structure. That's why we like to confuse you, right? That's part of the challenge of head and neck. The majority of tonsillar carcinomas arise within this tonsillar tissue. There are 2 other components of the tonsils, and they're actually well known to our ENT surgeons. One portion of the tonsil runs from the palate to the tongue base. And remember our Greek root. Remember we talked about lingua versus glossus? So this piece of muscle is known as the palatoglossus muscle, and it's also referred to as the anterior tonsillar pillar. This muscle goes from the palate to the pharyngeal wall. This is the palatopharyngeus muscle, and this is what's referred to as the posterior tonsillar pillar. So there's 3 components to the tonsil: the fascial or the palatine tonsil, the anterior tonsillar pillar, and the posterior tonsillar pillar, and we went over what muscles constitute the anterior and the posterior tonsillar pillar. So on the left is a schematic illustration of a spread pattern of tonsillar carcinoma. In the mid portion here, here's a tonsillar carcinoma, and there's a certain finding here that tells you that this really cannot be resected purely through an intraoral approach. And if you look at the space that's lateral to the pharynx, this triangular space, that's the parapharyngeal space, and on the patient's left-hand side, we can see this tumor has extended deeply to involve the parapharyngeal space. So this subtle, deep spread pattern illustrated here on the left-hand image indicates that this patient, if they wish to be treated surgery, would have to have both approaches. Really, in 2015, most of these patients are treated with combined chemotherapy and radiation therapy. However, there's some tonsillar carcinomas that the surgeons may feel that can be easily resected intraorally, but this essentially, both of these are actually relative contraindications to that because, again, another example of deep spread into the parapharyngeal space. So number 1 is going to be squamous cell carcinoma. Now, as I mentioned before, we have to understand the normal constituent anatomy or the composition of the anatomy. So what do you think would be the second most likely diagnosis? It's not squamous cell carcinoma, so what would be number 2? Lymphoma, exactly right. And now we know it's lymphoma. Why? Because of the palatine or the fascial tonsil contains lymphoid tissue. So naturally, number 2 would be lymphoma. A nice example here of enlarged, if you will, blandish lymph nodes, and there is a metastatic, or involved, I should say, retropharyngeal lymph node from lymphoma. Similar to what we saw before about lingual tonsillitis, you can have asymmetrical tonsillar tissue. And again, one of these is squamous cell carcinoma, and one of this is just an enlarged tonsillar tissue. Now, which one is which? Well, there's squamous cell carcinoma on your right and tonsillar asymmetry on your left. Again, if you're in a community-based practice and you don't have the cell phones of all your ENT surgeons that you feel comfortable calling, it's totally appropriate, at least in my opinion, to go in and just correlate with your physical exam. And this one on your left-hand side would be nice and soft. On the right-hand side, this would be rock hard. So on the right is your squamous cell carcinoma, and on the left-hand side is your tonsillar asymmetry. What about this diagnosis? It looks kind of nasty when you first look at it. It looks kind of big and ugly, but then we see these guys right here. So real quickly, someone shout out the diagnosis here. Yeah, exactly, tonsilith. And tonsilith is typically due to chronic inflammation of the tonsils, again, the palatine or the fascial tonsils, and if it's been around long enough, it can deposit some dystrophic calcification. So the tonsillits can be bilateral in this case or unilateral, as in the case on your right. Now, this was an interesting case. Again, this was one of my misdiagnoses because I looked at this and I thought that this was just going to be a tonsillar cyst or a retention cyst. You know, one of the papers I'm still working on my own institution, we have 140 cases of pathologically proven branchial cleft cysts or branchial cleft anomalies. And we're sort of familiar with the Bailey classification, and Dr. Sam showed some typical second branchial cleft cysts. Well, Bailey actually described 4 types of second branchial cleft cysts, and this, in fact, is a type 4 second branchial cleft cyst. And what's interesting is that the type 4s are located deep to the carotid space, or if you will, the carotid sheath. And oftentimes, these cysts that are in these atypical locations are oftentimes referred to as retention cysts or unusual cysts. And in actuality, these are probably remnants of branchial cleft cysts that if you go back and, you know, it's fascinating for me to read the old literature, to go back and read Bailey's article in 1929, I find it fascinating. It tells me how smart these people really were because we still oftentimes use these classifications. So if you see these cysts in the tonsillar area and you say, wow, I wonder what that is, but in the back of your mind, think of, could this be a branchial cleft cyst? Well, here's a tonsillar abscess. And this is a tonsillar abscess, and from an ENT surgical standpoint, this can be referred to as a peritonsillar abscess. Now, the difference is, in fact, we learned this last year at the course, was that radiologically we'll call this a tonsillar abscess, but our referring physicians may refer to this as a peritonsillar abscess. When I think of peritonsillar abscess, I always felt it was peritonsillar region. So anything that involved the parapharyngeal space or the tonsil or the soft palate would be quote-unquote peritonsillar. But in actuality, what our referring physicians tell us that if it's actually within the capsule of the tonsil, then that's what they refer to as a peritonsillar abscess. So radiologically, I'll call this a tonsillar abscess, but clinically, this is oftentimes referred to as a peritonsillar abscess. This, on the other hand, is an abscess involving the parapharyngeal space. The difference is that if the abscess is limited to the tonsil itself, this can be drained intraorally. However, if it involves the parapharyngeal space, then this would have to be drained surgically. Why am I so confident this? Because this was a case back when I was at UNC. It was initially called a tonsillar abscess. Multiple attempts were attempted to drain it intraorally. Nothing came back. The next day they brought it to us and we said, well, it's in the parapharyngeal space. And the child went to the operating room the next day to have it drained. The next area of the oropharynx is the soft palate. And again, this is Waldeyer's ring. So here's the lingual tonsillar tissue, here's the adenoidal tissue involving the tonsil, and here's the nasopharyngeal adenoidal tissue. So this gray right here forms Waldeyer's ring. The soft palate, as we discussed earlier, looks sort of like a Roman arch to me. So if you will, the top of the arch is a soft palate. The walls of the arch, I always look at it as being involved by the tonsils. And the top of the Roman arch is tethered by the 2, if you will, Italian muscles. And those are the levator and the velli palatini muscles. So those muscles tether the top of the palatal arch to the skull base. Radiologically, here's a squamous cell carcinoma involving the soft palate. They tend to have a circumferential appearance to this, and this is an ulcero-infiltrative carcinoma involving the soft palate. This is another example of a squamous cell carcinoma involving the soft palate, T1 weighted image with contrast demonstrating an aggressive mass extending to the junction of the hard palate and the soft palate. Another coronal image, here we see a squamous cell carcinoma on the coronal image involving the soft palate, and here we see it on MR, a contrast-enhanced T1 weighted imaging with fat suppression. So again, the number one tumor, as with anywhere in the visceral space, is squamous cell carcinoma. Now, one other thing we have to consider from a value-added standpoint is here's a squamous cell carcinoma involved in the soft palate. Now, there's a finding here that tells you it's probably going to be unresectable. And what is that finding? Well, if you look at the normal surface anatomy, here's the torus tubarius, here's the opening of the eustachian tube, and here's the fossa of Rosenmuller, we can see that surface anatomy is obliterated. And when we look at the skull base, this tumor is growing superiorly into the nasopharynx, and here we can see replacement of the normal marrow that should be in the petrous apex by this tumor. So this indeed was superior spread of a squamous cell carcinoma. All of this was submucosal. It could not be seen clinically. As a result, when they looked at the imaging studies, this patient was deemed unresectable. So squamous cell carcinoma is number one, and what do you think number two is going to be? Now, is there adenoidal, is there lymphoid tissue in the soft palate is the main question. There's not, right? So number two is going to be, what do you think? Minor salivary gland tumor. So embryologically, when the soft and hard palate form, there's a higher proportion of remnants of minor salivary gland tissue in the hard palate and the soft palate. So from a differential diagnosis standpoint, number one is going to be squamous cell carcinoma, and number two in the soft palate is going to be minor salivary gland tissue. And this is just a little interesting case. Here's a lesion that's involving the soft palate. It contains fat. And so what's the differential for a fat-containing lesion in the soft palate? I think lipoma is one, and what's the other germ cell tumor that contains fat? Yeah, dermoid, yeah. And if it's fat plus calcium, it's teratoma. But if it's just fat alone, then we tend to consider dermoid. So let's move on to the oral cavity. So the first area of the oral cavity is the buccal region, and this is located between your cheek and your gum. So as I mentioned, I was just in India a little while ago. One of the higher incidence of buccal carcinoma is felt to be due to the chewing and the sucking of the betel nut. Now, whether it's due to some direct toxicity from the aflatoxins or the storage of the betel nut, I still haven't gotten a firm answer on that, but you have to remember that sometimes this is referred to in that cultural context. So there's our space for the buccal carcinoma. Here's a contrast-enhanced T1 weighted imaging demonstrating the enhancing buccal carcinoma. And here's another example of a gingival buccal sulcus carcinoma. Again, we don't need to get a CT scan to make the diagnosis, but what we always want to do is to look at the underlying bone to see if there's any bone erosion. So again, back in the old days when I was a resident, it took a while to do the bone windows at that time. Now we have high-resolution bone algorithm. I hope all of you in the audience are reconstructing all of your neck CTs in bone algorithms. This is also referred to as a snuff dipper's carcinoma. So I don't know if any of the audience dip snuff. Anybody here? So I don't know. I'm from Kentucky. Anybody from Kentucky? Nobody? See, I'm a redneck Hindu, so I grew up in Kentucky. Never heard that one before, right? So, so when I grew up, it would put a little snuff between your cheek and your gum. I'd hang out at the 7-Eleven. You never would have guessed that about me, right? So, anyway, snuff is actually back. If you do go hang out at your local 7-Eleven, which I tend to do on a Friday night, snuff is not free, and it's free powder anymore. It's actually in little packets, and some of these packets are flavored with lime and cherry and peppermint, and they're not targeting middle-aged men like me, but I think obviously they're targeting the younger generation. So you put the little packets between your cheek and your gum and put you at higher risk. You can perform CTs with these, and we tend not to do things like the puffed cheeks. I think you potentially can see the lesions better, but really the physicians, the clinicians that I've worked with before, they can see the lesion well. What they're, again, looking for the deep extent in the bone algorithm. So we tend not to do the puffed cheeks or other maneuvers such as this. So number one is squamous cell carcinoma. What do you think number two is going to be? It's a tough one. It could be one or the other. It's actually lymphoma, number two. Lymphoma is the second most common tumor that arises within the buccal region. So number one, squamous cell. Number two, lymphoma. Now, what about some other lesions that can involve the buccal space? And again, you've probably figured out I've got a pretty boring life. Like I'll spend like a beautiful sunny day reading literature that's 100 years old. It's one of the oddities of my genetics, I guess. But there was a fascinating paper written in the 1960s by Laskin, who was a dentist. And I think I met him actually a while ago. It was kind of fascinating. But he wrote the typical spread patterns, not of tumors, but of infections. So if you have an odontogenic infection and it erodes the buccal cortex of the mandible, then this infection is going to extend out into the soft tissues in the buccal space. So you can actually have buccal space abscesses. And if you see something like this, it's important to go back and look at the bone to see if there's any erosion of the cortical bone. So if you see something like this, certainly you have to think skin infections, but in the back of your mind, you have to ask yourself, could this be spread from an odontogenic infection extending anteriorly? And this was another buccal space mass. This, in fact, was just a little lymphatic malformation. Again, a fluid collection, no appreciable enhancement. This was just a pretty simple lymphatic malformation. For me, in this case, it's not necessarily important where the lesion, what the lesion is, but just make sure you can map it into the buccal space. So the second area in the oral cavity is the oral tongue. And as I mentioned before, there's the circumvallate papilla. Here's the circumvallate papilla. Here's the foramen cecum. So anything anterior is referred to as the oral tongue. It can also be referred to as the mobile tongue as well, too. So either one of those terminologies is acceptable. So on the left is a schematic illustration of squamous cell carcinoma. Both of these are examples of squamous cell carcinoma. The one in the middle here extends to midline, and the one on your right here, a little off midline. Again, very bland appearance, nothing fancy about it. Number 1, 2, and 3, the most common tumor to involve the oral tongue is going to be squamous cell carcinoma. But what about this case? Here's an example of a newborn child. We see a fat-containing structure. We do a CT scan. We see diffuse calcification. So fat and calcification equals teratoma, exactly right. And there is a teratoma that was removed at resection. The teratomas tend to be midline lesions. When you have midline lesions in the craniofacial area, these are oftentimes associated with other midline abnormalities. In this case, we see a bifid tongue. And this kid actually had duplication of the pituitary stalks as well, too. So when you do see these midline tumors, remember there can be associated midline abnormalities. Other things to look for would be not only the duplicated pituitary stalk, but remember to look at the corpus callosum, because you can have agenesis of the corpus callosum as well. This was another kid that had a teratoma. One thing I've learned over time is that radiologically, at least for me, when you start seeing these punctate calcifications, it's difficult to differentiate between a benign and a malignant teratoma. These calcifications don't look too bad. I think, they're not really the aggressive type, but this was actually an immature / malignant teratoma. So from my standpoint, if I can make the diagnosis of teratoma, that's great. I'll let the pathologist determine whether it's benign or malignant, i.e. mature or immature. I think radiologically it's very difficult to do. And this was just diffuse enhancement of the tongue. This was a large hemangioma, a vascular malformation of the tongue. So we talked about the floor of the mouth earlier. So again, we'll go over the anatomy. Anatomy. So remember the analogy that I gave you about the teacup. So here is the mandible. Here's the mylohyoid muscle, and this muscle goes from the hyoid bone to the bottom of the tongue. So this is our hyoglossus muscle. Medial to the hyoglossal muscle is a sublingual artery and the sublingual vein. Between the little notch right here, between the mylohyoid muscle and the hyoglossus muscle, we have another vein, and we have this little green structure right here, which is what? Anybody remember what duct it was? Starts with a W. Warthin's duct, exactly, also known as the submandibular duct. So anatomically, there we're getting to our teacup, and there's our teacup again. So think of the rim of the teacup again as the mandible, the wall of the teacup as the mylohyoid muscle, and the base of the teacup here by the hyoid bone. So everything within the teacup is in the floor of the mouth. Now, earlier, as I mentioned before, we head and neck guys, we like to fool you. I referred to as this same space earlier as a sublingual space. But now we're going through the classification of the oral cavity and the oropharynx. When we talk about the oral cavity, this is now referred to as the floor of the mouth. So here's an example of a floor mouth carcinoma. This is what the referring physician sees, and this is what we see radiologically. These floor mouth carcinomas, they can enhance, they may not enhance. I showed a very subtle one earlier that just had a little bit of obliteration of fat in the sublingual space. So for me, the enhancement doesn't help that much. The key thing is the symmetry, symmetry, symmetry. And remember to compare one side to the opposite side. So squamous cell carcinoma is number 1. What do you think number 2 is going to be? Lymphoma or minor salivary gland? Minor salivary gland, exactly right. And this, in fact, was mucoepidermoid carcinoma involving the floor of the mouth, because there's not a lot of lymphoid tissue within the floor of the mouth. Again, if you're nutty like me and you actually go back and read Rouvier, 1936, one of the most boring books I've ever read. I just limited myself to the head and neck, but from what I do, it's probably one of the most helpful things I ever read. Because Rouvier did describe small little lymph nodes in the sublingual space itself. We tend to think of the level 1 lymph nodes in the submandibular space, but there are some tiny lymph nodes in the sublingual space. They oftentimes don't get involved, or we can see radiologically. But having said that, that larger component of remnant tissue is going to be minor salivary gland tissue. So here's an example here. I don't know if I showed this before. A little guy right here presents with the obstructive sialadenitis. So that's a little Cyalith involved in the floor of mouth. I think I showed that one earlier, the little Cyalith here. And remember, again, from Laskin's work, anytime that you have an odontogenic infection, remember, if it eroded the buccal cortex, then what space would the abscess be in? It would be, yeah, in the buccal space. But if it erodes the lingual cortex, then this is how you develop a floor of mouth abscess. So it's always important to go back and look at the bone and to see if this is of odontogenic origin. Now, just for grins, if this infection was involving the molar tooth, the second or third molar, and the abscess and the erosion extended posteriorly, then you would develop or at risk for a masticator space abscess. So again, a lot of these are based on the spread patterns and exactly what part of the bone is eroded. Ludwig's angina was actually described by Wilhelm Friedrich Ludwig in 1836, right? And the interesting thing about Ludwig's angina is that certainly it was made before CT and MR. And with all due respect to the cardiologist, they stole the term angina from us, because angina was actually means strangulation. And so when Ludwig described this, what he actually described was based on clinical examination. So this was actually a clinical Ludwig's angina demonstrating all this inflammation. Now radiologically, what we see in Ludwig's angina is essentially a compartment syndrome with multiple abscesses. So why does the patient get strangulation? Well, because these abscesses and inflammation cause the tongue to extend posterior superiorly, which compresses the airway. And if you look here, the epiglottis is actually swollen as well too. So that's why the patients get this strangulation feeling. And somehow the cardiologist stole the term angina from us, but the original term was actually strangulation. How was this treated? Well, the surgeons can go in, do a midline incision, and in this case they use a figure or take a rangeux, if you will, and try to eliminate all the septations and place drains to drain these abscesses. Anterior midline lesions involved in the floor of mouth. We have epidermoids. Why is that caused? Because the fusion of the midface tends to be symmetrical. If we get a little bit of ectoderm that's pinched between the developing craniofacial bones, we can develop this epidermoid. This we talked about earlier. This is the ranula. If the ranula is located above the mylohyoid muscle, it's referred to as a supraranula. Ranulas can be unilateral or bilateral. And one of the things I've learned over time is if I see something on one side, I sure start to look at the other side. And sometimes these things can be pretty small. If the ranula extends and extends inferiorly, then it becomes a complex diving or plunging ranula. And these ranulas can be tricky too, because they can extend posteriorly in the parapharyngeal space. And in this case, the ranula did extend inferiorly. And I think I mentioned the importance of this before, because if it's just intraorally, these can be marsupialized. But if it extends through the mylohyoid muscle, it requires a cervical excision. We talked a little bit about the thyroglossal duct remnants. This was just a small little thyroglossal duct remnant involving the sublingual space. Again, anywhere the course of thyroid gland descends, it can leave little droplets. If the droplets are solid, then that's what we refer to as ectopic thyroid tissue or thyroglossal duct remnants. And in this particular case, this was just a large arteriovenous malformation involving the floor of the mouth. Here we can see these big flow voids. So the next area that we'll talk about is the retromolar trigone. Now the retromolar trigone we're actually all familiar with if we can remember to name the teeth, right? So we have the central incisor, lateral incisor, canine, first premolar, second premolar, first molar, second molar, third molar. So the retromolar trigone is this triangular space that's behind the third molar. Now, how many in the audience have had your wisdom teeth out? And what you probably don't know is that you have the largest retromolar trigones in the room. Did you ever know that, right? Because essentially, what you do is when you take your third molar out, you remove your wisdom teeth and you increase the space of the retromolar trigone. So that's, I bet you never knew that, but that's for free anyway. So of all the tumors that I've seen, the retromolar trigone is probably the most understaged tumor clinically, because the retromolar trigone is behind that tooth. And based on the normal spread patterns, these tumors can grow along the superior constrictor muscle, go to the pterygomandibular raphe, and continue along the buccinator muscle. And it's really hard to see all of that spread pattern on clinical exam alone. Similarly, the bulk of the tumor, if this tumor was located within the oral tongue and you had a certain amount of volume, there's not going to be any bone erosion. But if you stick that tumor and you place it in the retromolar trigone, as that tumor grows, it's more likely to erode the bone. Why? Because the anterior aspect of the mandible is just behind that little triangular space behind that last molar tooth. So in general, at least in my experience, retromolar trigones tend to have a little bit higher likelihood of earlier bone erosion compared if you took that same tumor and put it in a different location in the head and neck. So the last area that we'll end up with is the hard palate. So we already talked about the teeth, but now we'll talk a little bit of applied anatomy. So this anterior area is the incisive canal. This plate right here is actually the junction between the sphenoid bone and the posterior aspect of the hard palate, and here are the pterygoid plates. So if you can have cysts involving the incisive canal, this was an incisive canal cyst. They can look somewhat ominous. You look at this and say, wow, that looks pretty bad. But if you're not sure, look at that transition zone between the cyst and the surrounding bone. Notice how we don't have that scalloped, eroded, moth-eaten appearance, and that crisp transition in this area really tells you that you're just dealing, in this case, with a very, very large incisive canal cyst. Squamous cell carcinoma is the #1 tumor to involve the hard palate. And here's our spread pattern. Here's a tumor involving the hard palate extending posteriorly into the masticator space. So here's squamous cell carcinoma. Again, schematically, this is what we see radiologically. Typically, the mucosa over the hard palate is just like 2 or 3 millimeters thick. It's not very thick at all. So if you see something like this, this corresponds with this patient's squamous cell carcinoma. Now, when the surgeon looks in, she or he, and I didn't want to say she or he, can look in there and does not know whether or not the bone's eroded. If indeed there's no bone erosion, then these tumors can be easily resected through a wide local excision. But on the other hand, if we, the radiologists, say that bone's eroded, then the patient will have to undergo some type of maxillectomy in order to resect it. Again, oropharynx tumors are typically better treated with chemotherapy and radiation therapy, whereas tumors such as a hard palate, I think, obviously it's going to depend on the institution, but most institutions I've worked at are still preferentially treated with surgery. But again, that differentiation, it's very difficult for the surgeons to determine whether or not that underlying bone is eroded. Again, that's the value that we add as radiologists. Another example here, but it's not squamous cell carcinoma. So what do you think #2 is going to be? Minor salivary gland or lymphoma? Minor salivary gland, exactly right. And there's no way that I can distinguish between squamous cell carcinoma and minor salivary gland. It's got to be just by statistics. Squamous cell is #1, and minor salivary gland is #2. They can have more of a benign appearance like this or a much more aggressive moth-eaten appearance, as you see in the middle and the images on your right. Now, one thing about minor salivary gland tumors that could tip us off, is that minor salivary gland tumors have a propensity for perineural spread, as does squamous cell carcinomas. There's no doubt either one could. But if you do see smaller volume lesions that have perineural spread, then you may want to think of minor salivary gland tumors. So anytime a tumor of the hard palate extends back involving this, and let me just draw this out real quick here, because I love to draw, right? I didn't have a lot of money growing up. I couldn't afford an Etch-a-Sketch, so now I finally can Etch-a-Sketch here, right? So what's the name of the foramen right here between the sphenoid bone and the little bone right here, the palatine bone? That's our sphenopalatine foramen. Then we have a fossa that goes from the pterygoid plates and the palatine bone. So that's the pterygopalatine fossa. And then we have the pterygomaxillary fissure. It almost looks like a vuvuzela or a trumpet, if you will. So we have the foramen, fossa, and fissure. Sphenopalatine foramen, pterygopalatine fossa, pterygomaxillary fissure. There you go, right there. So the V2 runs in the roof of the pterygopalatine fossa. So anytime that we have tumors that are extending back here in the pterygopalatine fossa, they can jump along V2 and grow posteriorly. Now, typically, the referring physicians knows that you're already dealing with a malignancy. Why? Because the patients typically present with numbness. They can look in and see a mass, and if the patient's numb, they know something's bad. But what they don't know is what is the proximal extent of the tumor. Now, so if indeed the tumor is located to the hard palate, remember the one I showed before, they could do a maxillectomy. But on the other hand, if we as radiologists say the tumor is in the pterygopalatine fossa, and now there's retrograde perineural spread along V2, and this is foramen rotundum into the cavernous sinus, at most institutions now, this is not being treated with surgery, but at most institutions it's chemotherapy and radiation therapy. Years ago, when we would show this, at least there was some skepticism amongst our skull-based surgeon. They would say, well, you know, I'm not sure if I believe that. But now I think over the last 20 years or so, there is great acceptance that radiologically we can detect these. In fact, the radiological findings oftentimes precede the clinical findings. So if we show this now, oftentimes these patients will now be treated with chemotherapy and radiation therapy. And in fact, just think of the type of surgery this patient would have to undergo. It's almost like a hemihedectomy, right? They'd have to take out part of the clivus. They'd have to take out the cavernous sinus, right? And the cavernous sinus is the main venous drainage for that deep portion of the brain, and also take out, what, cranial nerves 3, 4, 5, and 6. Pretty morbid procedure, right? So now, in general, that tends to be avoided, I would say, at most institutions. So in summary, what I've tried to do was go over the anatomy, the oropharynx, and the oral cavity. We went over the subsites. We focused on differential diagnosis, and why don't we stop there? We'll go for lunch, and we'll see you at 1:15, I think. Thank you very much for your attention.